So, so I think we'll go ahead and get started in the interest of time, and as people trickle in, that's fine. There was just a change in the schedule, so Dr. Panni got stuck in surgery, so we're going to go ahead and move forward with Ray Jin. And so Ray Jin, obviously you all know him, and he helped organize this. I was just going to briefly introduce him because I've known Ray for quite some time. So Ray did his MD PhD training here at WashU, and then as he mentioned earlier, we were postdocs together. Ray's in the division of gastroenterology and oncology. He's a practicing clinical oncologist who really manages patients with esophageal and gastric cancer as his main focus. So today Ray is going to be talking about some systemic treatments for gastroesophageal cancers. So please join me in welcoming Ramon Jin.
Thank you so much. So as Jose said, I'm Ramon Jin. I'm a upper GI oncologist here at Siteman. We heard Dr. Kushner talk about some of these endoscopic treatments. We're going to hear Dr. Brandt and Dr. Panni talk about surgical treatments. And then Dr. Vlacich, he'll talk about radiation treatments coming up. But I wanted to talk about systemic treatments for gastroesophageal cancers. So systemic treatments are what oncologists like me administer. These are usually IV medications, but can be pills. They kind of get absorbed and really penetrate your entire body and attack cancer wherever it is. So I am an upper GI oncologist. I treat esophageal cancers, gastric cancers, but also everything in between, these GEJ adenocarcinomas. And from my perspective, in terms of treatment, there are two basic groups. No problem. Two basic groups here that the first group is patients that we're intending to cure. These are not stage 4 patients. These are earlier stage patients. And then patients that are stage 4 that we can't cure, we kind of treat them palliatively. And that means we're trying to improve their quality of life and quantity of life. In 2025, there's a lot of diseases we can't cure. I tell all my patients this, like type 2 diabetes, high blood pressure. We manage it, and we kind of deal with it as a chronic disease. So in terms of both of these baskets, there's basically been essentially practice-changing advancements in the last year or two. And there are 4 big studies that I would like to really talk you guys through. And hopefully, as we continue the symposium every year, we can update this, but this is the 2025 update. So the first study, and these studies are kind of acronyms, if you will, but they don't really stand for anything, unfortunately. But the first study is called ESOPEC, and it applies to esophageal cancers, specifically esophageal adenocarcinomas. And the actual study was published in basically the premier journal for us physicians called the New England Journal of Medicine. It was published in January of 2025, and this is the title, Perioperative Chemotherapy or Preoperative Chemoradiotherapy for Esophageal Cancers. And what it sought to do, this is what we call a study schema. So it sought to really compare the old standard of care, which we call CROSS, and that is really chemo and radiation. So this is 41.4 gray of radiation combined with chemotherapy called paclitaxel carboplatin, given once a week, 5 weeks. And then 4 to 5 weeks afterwards, these patients proceed to surgery. So that was the old standard of care. So with the study, randomized patients to that or what they're testing, which is this new chemotherapy regimen. It's called FLOT. That is an acronym. Does stand for something. It stands for 5-FU, oxaliplatin, docetaxel. It's given as a 2-week cycle. So 4 cycles equals 8 weeks. You get 4 of those, you wait the same 4 to 6 weeks, you proceed to surgery, and then after surgery, you get 4 more cycles. So this is what we call a perioperative chemotherapy approach. So they're looked at many outcomes, and one of the first outcomes that I like to point out is this outcome. So this is a pretty busy table, but let's just focus on this red box. It's called pathologic complete response. And what that means is after surgery, when the surgeons take out all the cancer and the lymph nodes, they looked for what we call viable tumor. So if there is no viable tumor, that's what we call a complete pathologic response. That is the best that we can hope for. So patients who underwent that perioperative chemotherapy, 16.7% of them had no evidence of cancer at the time of surgery. So you can almost think that those patients didn't really need surgery. Compare that with the old standard of care cross for esophageal adenocarcinomas, path CR rates about 10%, okay? So now let's look at some other survival metrics. And as physicians, we like to look at these metrics in what we call, these are Kaplan-Meier survival curves. So the patients, we start off with 100% of patients that are randomized to the FLOT or that cross regimen, about 220 in each group. And then over time, as an event happens, and I'll talk what those mean, this curve falls, okay? So this top curve here, the event that we're looking at is death, and we call this overall survival. And you can see that the FLOT curve in red is atop that blue curve, which is that pre-op chemoradiotherapy or cross. If we look at not death as in the end event, but recurrence of that cancer, that's this graph down here. It's what we call progression-free survival, and it looks very similar. Basically, that flat curve in red is atop that blue chemoradiotherapy curve. So these are our kind of definitive, I won't show the statistics here, but this is definitive, relative definitive evidence that perioperative FLOT may be superior to chemoradiotherapy. We're going to have a discussion afterwards with our surgeons and our radiation oncologists about whether this is what it is, and we'll talk about more about that, the details. So that's so I can't say it's definitive. That's not the right word. But so ESOPEC kind of established, I think that's a better word, perioperative FLOT as a possible gold standard to treat esophageal cancers. Now this perioperative FLOT has already been used gastroesophageal junction and gastric. So this potentially unifies how we treat curative upper GI cancers. So this other study called Matterhorn asked the important question, can we improve upon that perioperative FLOT? And this study, again, published in our premier journal here just a couple of weeks ago in July, titled Perioperative Durvalumab in Gastric Gastroesophageal Junction Cancer. And what this study really did was take that perioperative FLOT I talked about, basically 4 cycles of FLOT, surgery, 4 cycles afterwards, and see if we can improve upon that by adding this drug called durvalumab. What durvalumab is an immunotherapy. It increases your immune system's ability to recognize and fight off that cancer. And immunotherapy, chemotherapy combinations have been approved and have been proven to be efficacious in stage 4 gastroesophageal cancers, but never in kind of this curative setting. So this was the first major study to show this. So let me show you the data. They randomized basically 1,000 patients, so about 500 and 500. And again, this is another Kaplan-Meier survival curve. And this is what we call, the endpoints here is death and recurrence of disease. And you can see that the durvalumab curve here in this, I guess, dark green is atop of that just placebo plus flat curve in gray. And again, here are the statistics, statistically significant improvement in that metric with the addition of durvalumab. Now, if we just isolate death as the outcome and look at overall survival, we see a very similar trend that durvalumab plus FLOT is superior to just that FLOT chemotherapy alone. And I mentioned that PathCR metric. You can see that addition of this immunotherapy called durvalumab to FLOT perioperative chemotherapy increases that PathCR rate to about 19.2%. Again, those are patients that at time of surgery, there's no viable cancer in any of the tumor specimens that the surgeons remove. And then with just FLOT alone, it's about 7.2%. So it's about 2.6-fold increase in that PathCR rate. So this is kind of the two major studies that recently come out and change how we treat, cure, and try to cure gastroesophageal cancers. But now I'd like to share some, I think, even more, I guess, exciting data in kind of this palliative realm in which we can't cure. Again, this is kind of, we try to improve quality of life and quantity of life. And anybody who's been in my clinic, I explained that this is biomarker driven now in 2025. And some of the key biomarkers that we test for include HER2, MMR status, which is mismatch repair. We test for this PD-L1, and this new biomarker called Claudin 18.2. And the reason we test for these biomarkers is now there's treatments that we can act upon if they're positive for these biomarkers. So Claudin 18.2 has emerged as a biomarker because there's a drug. And the two trials that proved that it was efficacious are called Spotlight and Glow. I'm just going to highlight one of them. They're sister trials that looked at different chemo combinations, but we'll just look at the Spotlight trial. And the drug that targets Claudin 18.2 is called zolbetuximab. And this is, again, another big phase 3 trial that looked at combining this Claudin 18.2 targeting drug with chemotherapy, and the chemotherapy here is FOLFOX, which is 5-FU, and oxaliplatin. And what is Claudin 18.2? As Dr. Guilford has already talked about, the normal cells in your stomach like to grow in sheets. And Claudin 18.2 is part of what we call junctional complexes. They kind of hold these cells in the normal stomach together. As the normal stomach transitions to becoming cancer, these cells no longer like to grow in normal sheets. They like to invade here. And these junctions are broken up. They become exposed to the surface. And this Claudin 18.2 can now be bound by targeting agents. Okay, so this is, the brown here shows normal Claudin 18.2 in the normal stomach. And then these are Claudin 18.2 in two different types of gastric cancers, intestinal type and diffuse type. So what did this trial do? Randomized about 550 patients, again, about 280 into each of these. One of the groups got FOLFOX, again, 5-FU oxaliplatin, and placebo, and the other group got this FOLFOX chemotherapy with zolbetuximab, which targets that Claudin 18.2 protein in those gastric cancer cells. So we'll skip that and just look at this, again, Kaplan-Meier survival curve. And their primary outcome was progression-free survival, which means no recurrence of that cancer, keeping that cancer in, I guess we can think about it in remission here. So you can see that addition of zolbetuximab to FOLFOX chemotherapy improved statistically that progression-free survival from about 8.6 months to 10.6 months. So this is statistically significant and clinically significant. So that is why we test for Claudin 18.2 now. Now let me talk about the final trial. This is called Destiny Gastric 04. It's kind of a mouthful, but what it really established is a second-line therapy for another biomarker we test for, HER2 positivity. So we've known for a while that HER2-positive gastric cancers we should treat with Herceptin and chemotherapy. but we've never known what to do after that fails. So there was no real continuing targeting of HER2 when that first line fails. Until very recently, with the advent of this new drug called trastuzumab deruxtecan. And this is a new type of drug. It's what we call antibody drug conjugate, or ADC. And what it does is it combines a certain type of chemotherapy with a HER2 antibody, actually 3 of these, so it can directly deliver that chemotherapy to HER2 positive gastric cancer cells. So this Destiny Gastric 04 trial really compared the previous standard of care is this kind of weak chemo, ramucirumab with paclitaxel, with this single agent drug, trastuzumab deruxtecan, that ADC to HER2. And this is in patients with HER2 positive gastric cancers who progressed on frontline therapy again. And you can see the 2 Kaplan-Meier survival curves for 2 different metrics. Overall survival here, superior with that trastuzumab deruxtecan in the gold curve over the old standard of care chemotherapy in the blue curve. Improves overall survival from 11 months to almost 15 months. And then that progression-free survival metric, which is the cancer is held kind of in remission. It improves that with this drug, trastuzumab deruxtecan, from 5.6 to 6.7 months. So I think this is what I would like to kind of impart. So in these 2 curative and palliative baskets, we have essentially practice-changing advancements that have come out in the last 1 or 2 years. There's, let me bring that back. So we're talking about perioperative FLOT here. We're adding durvalumab to that in the curative setting. We're testing for Claudin 18.2. We're targeting that with zolbetuximab. And now we have a new drug for HER2 positive gastric cancers in the second line setting. So first conclusion is that systemic treatments are improving survival for gastroesophageal cancers. I mean, this is just a fact. All those studies, that have been shown to be statistically significant, so this is a fact. But where there is still great need is, I've shown you those survival curves. Those are median overall survival. So 50% of the patients do better on those curves, 50 worse. We don't really understand, and we can't predict which patients are going to respond and not. Okay, so we need better patient biomarkers, better criteria for patient selection. And this is another area where we need to understand. So we're testing for these biomarkers. If a patient is positive for multiple of them, we don't really know the proper sequence. Which one should we give first? Which one should we give second? Is there a scientific or a clinical reason we should do one before the other? Should we combine them? We don't know this. And then, as you can see from all of those Kaplan-Meier survival curves, they eventually fall. They never flatten out. So all of those treatments eventually fail. And what was sorely needed is we don't understand why these cancers eventually develop what we call mechanisms of resistance, why those drugs no longer work. So I think, just to end, novel systemic treatment approaches remain a need and a priority for gastroesophageal cancers. So with that, I can take questions. I think we don't have a Q&A session at the end, so I can open up questions for a couple of minutes. Jeff?
Yeah, so I'll just ask one.
Yeah.
So it almost seems like, with ECAD being lost causing diffuse gastric cancer, Claudin 18 has the opposite effect. So my question was, you had likened ECAD to Claudin 18, but it almost seems like they have the opposite effects, where loss of ECAD causes or predisposes someone to develop diffuse gastric cancer, but you are blocking Claudin 18.2 to help people with gastric cancer. So it almost seems like Claudin 18.2 is a bad player, but ECAD's a good player.
Right. So that's an interesting point. So, what Dr. Guilford talked about in CDH1, those are mutations that cause loss of function of the protein. Claudin 18.2 is normally expressed in all gastric cells. And why it's effective and why it changes is because those cells, they lose kind of that adhesion requirement, okay? And those tight junctions actually become exposed. So it's not actually a functional gain of function, loss of function. It's just mechanistically they become exposed. That antibody zolbetuximab can bind and we can target it. So it is what we call antigens. It's a cancer antigen, and what's nice about it is it's not expressed in any other organs, okay? There's low levels, probably in the biliary tract and maybe in the bone, but very few other organs, so there's not a lot of off-target effects. So a lot of different companies are trying to target this Claudin 18.2 with ADCs, cellular therapies. It's a hot topic of research and interest right now.
I grabbed the microphone, so I guess I'll ask. But
Go ahead, Jose.
so along those lines with Claudin 18, do you know how early it gets sort of, you can detect it? And can you detect it in these precancerous stages? And should we be targeting it earlier, or does it only get expressed once a patient has actually developed cancer?
No, that's a good point. So what's interesting about 18.2, or I guess Claudin 18, Claudin 18 has two isoforms, 0.1, 0.2. Doesn't really matter, but like I said before, it is an inherent gastric identity protein. Okay, so in RNA-seq or anything, we see Claudin 18.2. That's a gastric signature. In IM, I don't know about kind of these gastric metaplasias, SPEM or pyloric metaplasia, but we know in IM, once you kind of lose your gastric signature and adopt that intestinal signature, you lose Claudin 18.2. So that's a very interesting point. And then in these cancers, why it comes back that emerge out of these IMs, I think it's because there's a lot of lineage plasticity in these cancers. They start expressing intestinal markers, but also normal gastric markers. So they kind of possibly re-express that as well.
Yeah, thank you. Really, really good talk.
Let's go for it.
Is anyone developing antibody drug conjugates against Claudin 18.2?
Yes, there's a lot of companies that are targeting 18.2. Some of the people here with booths outside, I'm not allowed to kind of say names, but there are a lot of ADCs in works. There's bispecific antibodies that try to target Claudin 18.2 and bring in CD3 positive T cells. There's CAR Ts that are being so those are chimeric T cells that have been engineered to recognize Claudin 18.2. So those are all kind of in the works. Yes, so again, an exciting area. But I do want to point out again that it's only about 30%, maybe 40% of gastric cancers are going to be Claudin 18.2 positive. Okay.
Doing for that type of other types of cancer?
Yeah, so I probably should have broken down this palliative, but we have different baskets, like I said. So there's this Claudin 18.2 basket that we target with Claudin 18.2 drugs. There's a HER2 basket that we target with HER2 drugs. There's another basket called PD-L1. So we're using certain immunotherapies like pembrolizumab and nivolumab that we can combine with chemotherapy. But that's it. Those are what we call actionable biomarkers. A lot of patients, each of those are probably between 10 to 20%. There's some overlap, but a lot of patients are going to be biomarker negative. And for those patients, unfortunately, we just are using kind of FOLFOX or variants of that kind of chemotherapy, and really no real advancements for them. Yeah, I mean, chemotherapy is the backbone for all these treatments, and in itself is pretty effective. But you know, obviously, it's kind of been around for a while, and it's toxic, hard to tolerate, and that's why we need to find better treatments and hopefully a future where we can kind of turn down these chemotherapies and rely on more what we call targeted therapies that are more effective, less toxic.
So we're well on our way with what's going on.
We're on our way, but you know, a lot of progress can be made. Okay, so okay, thank you. Okay, well now it's my pleasure to introduce our next speaker, Dr. Whitney Brandt. She's an assistant professor in the Department of Surgery, and she's really going to talk about new or surgical treatments for esophageal cancer. So help me in welcoming Dr. Whitney Brandt.
Hi, everyone. Thanks for having me here today. So I'm going to talk a little bit about esophageal cancer and how we manage that surgically. And just an overview, I'll give a little brief about the anatomy of the esophagus and then the things we think about surgically, the approach, and how we're going to recreate the esophagus. And then I'll talk about some of the data more recently and some older data about complications and newer technologies. So esophageal cancer is fairly common. In 2025, there were reported 22,000 cases, and there were over 16,000 deaths. So it's common and hard for patients. And if you look at the anatomy of the esophagus, it's here on the left. We tend to think of the length of the esophagus and divide it by upper esophagus, kind of middle esophagus, and lower esophagus, and then GE junction or gastroesophageal cancer. So they kind of span that. And the reason that matters is because, and what I'm going to focus on in most of this talk is the distal and mid-esophageal tumors. And that's because once you start getting higher, you have to kind of manage those a little bit differently. But the majority of this talk is going to be on middle and lower esophageal cancer. On the right, here's a picture that you may have seen already today, but this is just showing kind of the depth of the tumor invasion. And the reason I bring that up is because when it hasn't invaded the esophageal wall very, very deeply, then you can use endoscopic therapies. And that's great for patients because they can avoid the surgery I'm about to tell you about. Once it gets a little bit deeper or there are lymph nodes that are positive, then we have to start thinking about doing an esophagectomy. So I'll talk to you about those. Here, like on the left, you already heard about this, but early stage has some pretty nifty esophageal endoscopic resections. On the right, when things are more locally advanced and we have to do an esophagectomy, this is kind of a gist of what it might look like. We take out the esophagus and a portion of the stomach in most cases, and then you use the stomach preferably to recreate a tube like the esophagus and reconnect it to the proximal esophagus where there is no tumor. So there are a couple different ways we can do that operation. The fancy ways that we call them are transhiatal and transthoracic. That means you go across the whole chest and into the neck for transhiatal, and then transthoracic is in the abdomen and chest. Which conduit to use? How are we going to recreate the esophagus? The stomach is preferred, but sometimes we can't use the stomach. We'll talk about that, and we use colon or small intestine. And then how are you going to do the operation, open or minimally invasive with a robot technology, which is what we use here. So I'll first start by talking about the transthoracic esophagectomy. This is a midline incision, you can see on the top for the abdomen, and then a right thoracotomy, meaning right chest incision. And if you're doing this open, the incision on the right kind of wraps around to the back. The abdominal portion is getting the stomach kind of mobilized, and we're just trying to prepare that stomach and take out, if there's any little piece of tumor that's in the stomach, that's supposed to come out as well. But the whole point in this abdominal part is getting the stomach ready to use for the chest and taking out the very distal end of the esophagus. Once you get into the chest, this is an example. You can really see the whole esophagus. You can see the lymph nodes around it. You cut it, and then you reconnect the two together after you make a tube. So that's the general gist of the transthoracic. The transhiatal esophagectomy is a different approach with a similar kind of concept. Instead of going through the chest, you make an incision in the neck where you find the upper esophagus. And then the surgeon actually bluntly kind of goes around the esophagus from the abdomen. So they do that whole chest part with their hands and I feel. The connection is pretty much the same, but it's just in a different spot, slightly higher, because you have to be able to mobilize the esophagus. And then this is just a picture of kind of how we cut the stomach and this new tube that's created that we'll bring up to do the connection. Now, there's been a randomized control trial. This is now over 20 years old. And so it's not, but it's considered dogma now. And it was for mid to distal esophageal adenocarcinoma, like I'm talking about. And they split patients up into getting one of the two techniques. And not surprisingly, the numbers on the bottom, I'll kind of point out, is that when you went through the chest, patients had more lung complications. And that's not surprising because there's more pain. This was back in 2002, so there was very little minimally invasive techniques being used. It was all open. The differences in other outcomes were not really different. The number of lymph nodes resected was higher in the chest group, and that's because you can actually see the lymph nodes you're taking out. They looked at overall survival and disease-free survival, meaning did the cancer come back, and those outcomes were not different. But there was a slight favor towards doing the operation through the chest, and that really was thought to be attributed to the number of lymph nodes taken out. So really, at the end of the day, the operation's not much different from a cancer standpoint. And if you can get good lymph nodes, then that's all that matters. So the different conduits we use, the gastric, I mentioned, the stomach is the preferred. Usually we make this tube, and this is kind of how it looks. It's usually about 4 centimeters wide. We measure it in the operating room. And the perfusion, the blood supply, actually you have to cut some of the blood vessels to the stomach in order to move it up into the chest. And so it comes from the blood supply down here and then also over here. And then the tip up here is actually perfused by some of these vessels. So it can be up to 5 to 7 centimeters depending on where you have to make your connection in the chest or in the neck. And there are a bunch of different ways we can make this connection. The most common that we use here is with this stapler called an EEA. We actually sew a special anvil in the proximal the esophagus where we have cut. And then you take the stapler through the part that's going to come out into the tube, and then reconnect them. And then we end up having cutting up more of that gastric conduit. So there's actually, this is 95% of our anastomosis, and allows you to kind of use the conduit, make it a little straighter, and cut off some of the stomach that might not be have as great of a blood supply. This technique on the bottom is the Oringer technique. It is very commonly used, especially in minimally invasive resection. And it's a straight stapler, and then you sew the front wall. So it's just a different way, but this is the one we use right now when we do open esophagectomies. And we kind of prefer it because you can cut off some of that conduit. Now, other conduits, so sometimes the stomach is not a good option to use, and that's if the patient has a previous stomach surgery, then it's not going to be useful for that. If their tumor is in the stomach and you're not going to be able to get a good margin, meaning they're scared that if you use some of the stomach, there's still going to be cancer there, then you have to use something else. But when you do use the colon, it becomes a little more complex. So first you have to bring the colon up and connect it, and then there ends up being more connections because the colon's connected to the esophagus. Now you have to connect the colon to something else, and the colon has to go back to each other. So it makes it a lot more complex to recover from, and it's a longer operation. Usually we do these here in collaboration with our colorectal surgeons. So it's a dual surgeon operation at least. So it's just a little more complicated for patients. There's another thing called the jejunal conduit. This is a small intestine that can be used. At WashU, we don't use this all that much. Some centers actually prefer to use this instead of colon. It just depends on the institution and their comfort. Here, we usually use it for very high esophageal malignancies. This is a picture here where the piece of small intestine is actually hooked up to the esophagus in the neck, and then a artery is reconnected to an artery in the neck to help that have the blood supply. So that, if you can imagine, that also creates a lot of extra work and is very specialized. In any case, the completed reconstruction looks something like this. So the connection between the esophagus that's remaining and the new, usually gastric conduit, is in the chest. And then there's a valve that sits at the end of the stomach called the pylorus that sits right in between the chest and the abdomen that helps prevent some reflux. But really, the stomach works differently than the esophagus. Instead of contracting food down, it kind of is just a tube that sits there and allows food to drain down. So it's a little different for patients to eat. Things aren't getting pushed down, it just drains by gravity, and things can come back up from the abdomen, causing reflux. Usually here, how we take care of these patients, they have their normal postoperative recovery. They're started on a liquid diet early in their postoperative management. Some may or may not have a feeding tube. It depends on the surgeon. And they're usually discharged if everything goes well within a few days. I think I'm going slightly over, so if you want me to slow down, okay. So this is a big operation, as you can kind of see. It's a little complex. Your stomach is not meant to live in the chest. So your body doesn't really like that conformation very, very much, and it is associated with a lot of morbidity or complications. This is a more recent study out of 14 countries and 24 high-volume centers, so people who are doing the operations very commonly. It's over 2,700 resections, the majority of which got a complete resection, got all the tumor out, and the majority were done through the chest and had a stomach used as a conduit, but you can see that 59% of patients had some sort of complication. And there's a decent amount of patients here on the right that had more than one complication. One of the feared complications we always talk about as surgeons are leaking. So that means that the connection you made between the stomach and the esophagus kind of falls apart. And it's really important to us. This is, again, now like over 10 years, an older study, so it's a little outdated based on the new techniques, but we always worry about which patients are going to have that problem and preventing it. This study looked at over 7,500 patients who got the operation. About 10% had a leak, and the mortality of the leak was slightly higher than if they did not have a leak. And patients with heart failure, high blood pressure, and kidney problems were more likely to have a leak. These can be managed in different ways. Sometimes a leak is not, we just keep the patient without anything to eat and drain things. And if you had a neck incision, sometimes we can open the neck and that's all they need. So it's not very, they don't have to go back to the operating room, or it's not very morbid. Other times when it's leaking a little less and not well controlled, we have to put a covered stent in the esophagus temporarily to kind of seal that. Sometimes we put a little tube through your nose that drains through a vacuum. That's a little more advanced in certain different ways. And in extreme cases, but luckily it's rare, we have to actually take out that piece of stomach if it's not survivable anymore, if it's not living well. More recently, we've been doing minimally invasive esophagectomies. What this means, instead of having big incisions, you have small incisions, and we use the camera. This is a randomized controlled trial that was done about 5 years ago of 112 patients that either got a robotic esophagectomy or an open esophagectomy. And they had similar ages and divisions between the groups. The majority were adenocarcinoma. 80% had chemoradiation, as that was the standard back in the time the study was being done. And RAMI, which means robotic complications, were less, so 59% versus open, which was recorded as 80%. And of course, there was lower pain because the incisions were smaller and less heart problems after the surgery, but the long and other short-term outcomes were very similar. This last piece of data I'll show is that the high-volume centers tend to do more, and if you can imagine, this is a complex operation, so the more a certain center does, the better patients do. And that's not just the surgeon doing more, it has to do with that, but also the nurses, everyone in the hospital kind of is aware of the pathway and kind of knows how to manage these patients, which can be a little more complex. So I'll conclude there. Just going to say esophagectomy should be performed with a mortality less than 5%. That's the goal, but the morbidity still is high. And there is decreasing morbidity now with increased utilization of these minimally invasive techniques. And it's something we're still perfecting. Thank you very much.
Questions?
Well, thank you.
Yeah.
Yeah, thank you, Dr. Brandt,
Sure.
for this great overview. I have a question related to the talk from Dr. Jin. What is your preference on the perioperative treatment? I mean, the flood has more side effects.
Yeah.
Do you tailor it, or do you have a standard?
So, and we are going to talk about this a little bit later. So, from our standpoint, the radiation is harder to operate when patients have had preoperative radiation. It actually makes things stick a lot. And even, you know, we've seen this in lung cancer cases as well, which we commonly do, but things after just chemotherapy are not as stuck together. So it makes that part more complicated, just doing the dissection of the esophagus. The other thing we worry about is if you radiate part of the stomach that you're going to use to make your connection, the blood supply might not be as good. And we're already kind of stretched thin on blood supply, and you can see that that leak rate is like 10% nationwide. So we're worried that if there's a little bit of radiation to the healthy tissue we're trying to put back together, that can cause leaks, you know, like, because we're anxious about avoiding those. So those are the things in our mind that we're kind of cognizant of. And you're right, the FLOT technique that Dr. Jin talked about sometimes has patients, it's a little more challenging for them to deal with than the full Fox regimen, which was in cross. But our radiation oncologists have been good here too about not going up too high where we think we're going to make the connection and kind of staying close when we used to do cross frequently. But those are kind of the perspectives of most surgeons nationwide, I would say, have similar feelings about it.
Question?
Where is the sphincter valve located? This process with my esophagus,
Yeah.
my stomach.
So there's a muscle at the end of the stomach. You mean after an esophagectomy? What's that? Yeah. So there's a muscle at the end of the stomach that's normally there to kind of, once your stomach digests food, it kind of opens up and lets things go into the small intestine. That muscle we use is still there. We don't take that part out, and sometimes it can be too tight for patients right after the operation. So I didn't talk about this, but during the operation, we do some maneuvers to kind of loosen that so they don't get things just sitting in the stomach because it's not draining well. So that's either stretched sometimes with a balloon or we inject Botox, which relaxes the muscle. But that muscle also helps prevent a little bit of reflux. So it's kind of, you're trying to get it right in the middle. And it usually works pretty well for patients, but sometimes right at the beginning, patients need to have that stretched. Mm-hmm. Yeah, no problem.
Move on. So our next speaker is going to join us virtually. Let's see if we can pull him up. And it's Dr. Vlacich, radiation oncology, and he's going to talk about radiation treatments in gastroesophageal cancer. So let's give a hand with for Dr. Vlacich.
Thanks, Ramon. Can you guys all hear me okay and see my slides?
Yeah, we can hear you.
Okay, great. So my name is Greg Vlacich. I'm a radiation oncologist here, associate professor in the department, and I apologize that I'm not able to join in person, but I'd like to today talk about radiation therapy with gastroesophageal cancer. And so just kind of some brief objectives of our short talk today. I want to give a brief history of radiation treatment when involving treatment of the distal esophagus and gastroesophageal junction cancers with a focus on locally advanced disease, and then go into some details of our current radiation approach, then discuss the current state of radiation therapy and multidisciplinary care as it relates to locally advanced disease, and then discuss some future directions when it comes to radiation treatments in this space. So, for those of you who may not have some familiarity with radiation treatment, I just wanted to kind of give a brief overview of what it is exactly, unless someone's been through it or know somebody close to them that has. It often can be some kind of nebulous concept here. So really, radiation treatment is the use of high energy photons or X-rays to target tumor, whether it's gross tumor or microscopic disease. And you kind of think of it like an X-ray or CT scan on steroids as far as energy, but with the important caveat that we're focusing it on a specific part of the body that we're intentionally trying to treat. It's a focal therapy where higher doses is again intentionally targeting a specific anatomic location. So in some ways you can think of it as similar to surgery in that we're sort of focused in one part of the body as opposed to systemic therapy, which goes everywhere. In the majority of cases, it's something that's delivered externally, and the picture that you see here is a linear accelerator where the arm swings around and the radiation focused area is emitted from that linear accelerator head. Another thing to kind of keep in mind with radiation treatment and why it's important to think about is that normal tissue and organs that are in the path of the radiation can be impacted by the treatment as well. But there's no effect on normal tissue or organs that are outside the path of the beam. So if we're treating a rectal cancer, there's no exposure or risk to the lung or the heart, so to speak. Less commonly, radiation treatment does involve the use of radioactive isotopes, which are implanted either temporarily or permanently and delivered internally. So that's more of a procedure type of approach, but I'm not going to go into that today. And it's also, a pretty small portion of what we do for gastroesophageal tumors. And so, specific to us in the radiation field, I kind of want to first start by making the distinction between distal esophagus, GE junction versus gastric tumors. And so here's just a schematic of the anatomy of the stomach. And, this area here, the distal esophagus, GE junction, and the very proximal stomach, there's a clearly defined role for radiation therapy in the curative management in this case. But when we're thinking about, the more distal stomach, the body, and up to the pylorus, there's really a very limited role for radiation therapy and curative management. So I'm not going to be really, discussing that just because we don't really play a major part in, truly curative treatment of this disease. And so, kind of thinking about just the history of radiation treatment in the treatment of GE junction and distal esophageal tumors. So, when thinking about it in the context of people who are surgical candidates versus people who are not surgical candidates. So, with surgery, when we've looked at doing radiation therapy alone after surgery or before surgery, we found that there was no real, survival benefit over the surgery alone. And so radiation treatment on its own didn't seem to have any impact on how well we did with people who could get esophagectomies. When we started thinking about adding, a combination of chemo and radiation together, so first in the post-surgical setting, and this is where there's some overlap with true gastric cancer and where we have, potentially some role in curative management, though in practice, not really. We don't really use this approach very much at all. Is results from this intergroup 0116 trial from the 90s, which looked at surgery alone for locally advanced gastric or GE junction adenocarcinomas. Compare that to chemoradiation, which was sandwiched between chemotherapy after surgery. And so there was some benefit to do that approach. But again, it's not a treatment paradigm that's really something that we do anymore. And then in the preoperative setting, when we looked at doing chemo and radiation before esophagectomy, initial studies were trended towards a benefit, but it was still not really a clear, practice across the board. And it didn't really become the clear standard of care until the CROSS trial, which I'll talk about shortly. when thinking about non-surgical candidates, chemoradiation is really the definitive treatment option in that setting. Initially, a study back from the 80s compared radiation alone to chemo and radiation and showed superior outcomes with the combination of treatment. Even at 5 years with radiation alone, there were no survivors. And so, chemoradiation is really the only option for people who can't get surgery to potentially have curative treatment. And then, but when we try to improve on that in general, specifically looking at whether we could escalate radiation dose to try to improve the outcomes with chemoradiation, so far that has not shown to have any benefit. And so we've kind of had the same approach as far as the radiation dose, and to some extent the chemotherapy for quite some time. And so since the cross trial really informs a lot of what we do on the radiation side, I just wanted to kind of go into some more detail about this since I don't think we've really covered this just yet. So this was a study that was conducted in the 2000s, and it was comparing surgery alone to chemo and radiation followed by surgery. And so in the chemoradiation group, radiation that was delivered was 41.4 gray, which is our unit of radiation therapy over 23 separate treatments. And then chemotherapy was weekly carboplatin and paclitaxel, which essentially is for radiosensitization. And so what they found was in this study that chemoradiation didn't significantly impact the ability to get surgery. So 94% or greater patients in both arms went on to get the surgical resection, and it didn't appear to be associated with higher postoperative mortality, and it was 4% in both groups. Chemoradiation before surgery showed an improvement in overall survival, pretty significant in this study, so 49 months with chemoradiation versus 24 months without, and achieving a negative margin was significantly improved with the addition of chemoradiation. And Dr. Jin has kind of talked about the concept of complete pathologic response, and so how much of the tumor that's seen at diagnosis is pathologically gone at the time of surgery. And so in this study, 29% had a complete pathologic response. When they looked specifically at adenocarcinomas, it was a little less at 23%, but still, a pretty decent number. And then the chemoradiation had reduced local or regional recurrence, so recurrence in the esophagus or within the lymph nodes nearby, over surgery alone. And I'd say one distinction that I'd like to point out is that the radiation dose that they used in the study is specifically because these patients went on to get surgery. In our clinical practice, we tend to give a little bit more, in the definitive treatment range, since it's not a whole lot different than the 41.4 gray, and it also allows us, it doesn't put us in a situation where if for some reason the patient can't get surgery, that we've undertreated them for kind of potentially curative treatment. So before, if it's preoperative or if it's definitive, then we generally will treat to 50 gray, so a little bit higher than the trial here. So, so then, the current role of radiation therapy in surgical candidates, it's for preoperative chemoradiation based on the cross trial. And then for non-surgical candidates, it's definitive chemoradiation. But with the asterisk that will kind of, come back to this as far as, surgical candidates based on those studies that Dr. Jin had discussed. So kind of talking about as far as how we design the radiation treatment and what the process is like. So radiation treatment fields are based on where we know the tumor is and where we think microscopic disease is hiding. And so, gross tumor is delineated by CT, PET, or endoscopic ultrasound. This is just a snapshot of a PET scan. You can see that uptake in the center part of the chest there, identifying the tumor. And when we design the radiation treatment based off of a CT scan that we use for planning, we expand around the gross tumors in the radial direction, so left, right, anterior, posterior, as well as above and below the esophagus. And so, with the radial margins, that they're relatively modest to account for possible microscopic expansion beyond the confines of the esophagus or the lymph node. But kind of unique to how we, on the radiation side, manage expansions of treatment volumes with esophagus cancer, because there's a higher likelihood of submucosal spread. And this is based on older pathologic studies on surgical specimens that we treat a longer length above and below the primary tumors. And so that's something on the sagittal section here, you can kind of appreciate. I don't know if I have a pointer, but that above that red outline where the tumor is, you can see there's some extension above and below, more than it would be to the left and right. And so to Dr. Brandt's point, that does also kind of potentially complicate surgical management, since the goal is to do the anastomosis, the connection outside of the prior radiation field. And so, as I mentioned earlier, traditional radiation is done with photons, so X-ray treatments, but it does result in what we call lower dose spill into other areas of the chest and upper abdomen. You may or may not have heard of proton radiation, which is a newer technique that has a different physical property that significantly reduces this spill. Essentially, X-rays don't have any mass, and so they kind of, traverse the body without much change. But protons do have mass, and so we can design it so that the radiation essentially stops deep within the body. And this figure here kind of shows that spill area. So all that sort of dark blue are lower doses of radiation therapy that are sort of necessary, or we kind of accept just based on the physical properties of the X-ray. Whereas the on that left side, the PBT, which is the protons, where the proton beam enters, there's radiation dose, but past that, in this case, you can see in the heart, there's really effectively no radiation dose there. There's been some institutional studies that suggested a potential advantage to protons for reducing side effect risk and improving survival, both in the preoperative and the definitive setting. And there's currently a large multi-center trial, the NRG GI 006 study, more directly comparing these two treatment modalities. And so from this graph on the figure with the squares, that shows the radiation dose with the protons, the triangles with the X-rays. And you can see that the square relative to the triangle with the same color, those are organs that are seeing much less radiation treatment. So. And then, as far as side effects from radiation therapy, during the treatment, folks can get fatigue, some pain or difficulty swallowing, since the lining of the esophagus can get pretty irritated from the radiation treatment, and then skin reaction too. And then some late side effects, things that we kind of think about when we treat this type of tumors: inflammation of the lung nearby, which can cause some cough, shortness of breath. If there's enough lung that's treated, there could be potentially more serious side effects. There can be, especially for folks that don't get surgery, some scarring or stricture of the esophagus. And so we treat the underlying tumor, which often causes pain or difficulty with swallowing, but we may end up causing similar issues just from the radiation itself. And then there's also the concern of damage to the heart. Coronary artery disease and pericarditis are some of the more common possible side effects there. So, to kind of go back to the role of radiation therapy. So, in the 2025 edition, I think, obviously takes into account some of these seminal studies that were published earlier this year, that Dr. Jin had mentioned. And so, I think now we're starting to really appreciate and learn how best to integrate radiation treatment in the treatment of these patients. And so, generally speaking, for healthier patients who we think can tolerate more aggressive chemotherapy, then the FLOT with or without immunotherapy is generally the preferred approach. For patients who may not be able to tolerate that, then we still would consider preoperative chemoradiation. But we're starting to appreciate, and we'll talk more about this in sort of the group discussion later, is that in the postoperative setting after FLOT and surgery, if there are risk factors for local or regional recurrence, is there a role for radiation treatment afterwards? I'd say overall it becomes quite a bit more complicated from our perspective, and so that's a kind of open question. And then one thing, I don't know if we've talked much about the difference in histologies, but the thing I'd point out as far as radiation goes is that esophagus tumors can be adenocarcinoma, which are similar to gastric, or squamous cell carcinoma. So the different histologies are important. For squamous cell cancer, those studies above are specifically for adenocarcinoma. So preoperative chemoradiation is still the standard approach. The cross trial showed about 50% complete pathologic response in this histology. And so, and we do occasionally see squamous cell histologies in the distal esophagus close to the stomach too. So, so it does still kind of factor in. And then for non-surgical candidates, still definitive chemoradiation. And then just quickly, future directions is really determining the role of protons. Is it really something that is going to provide better outcomes? Since it's a limited resource, it's expensive, and so we want to be sure that it's something that is truly of significant benefit. And then can we use different radiation schedules or boost techniques to improve outcomes, particularly for non-surgical candidates? And this is something where we try to do more radiation dose per treatment to see if we can shorten the course of radiation and improve the outcomes. And then integration of immunotherapy with radiation. We know that radiation treatment can, increase immunogenicity, but it can also impact the immune system function directly by affecting immune cells because they're sensitive to radiation. So can we integrate those two? So, and with that, I'm all done. Thank you.
I think so. Okay, this is the right one. Thank you. Hi, everyone. My name is Roheena Panni. I'm a surgical oncologist and hepatobiliary surgeon, and gastric cancer and GE-junction tumors is one of the areas I focus on. One thing to emphasize here before we start is, as you can see from the lineup and different speakers, we all work very closely to each other. So the thoracic surgeons, myself, medical oncology, radiation oncologists, we all discuss every single case before we come up with a plan. So it's important to pay close attention to some of the things we talk about, but eventually it's not just one person making the decision, which is a place that you want to be at whenever it comes to complex and rare cancers like gastric cancer. So in my talk today, I will cover a little bit of details about the surgical procedures. I'll emphasize a little bit on the staging because for gastric and GE-junction tumors, the staging involves a surgical procedure, which is staging laparoscopy. And I'll talk about why it's important to consider. Second thing, which is very important, is markers of high-quality surgery. How would you choose where to go for your surgery for something that is a rare cancer in the United States? and some considerations on choosing the surgeon type for the kind of procedure that you would need. So staging laparoscopy, which is something it's a surgery that you have to complete most of the times once a tumor is diagnosed prior to starting your chemotherapy. And it's not ideal because sometimes we think that, a week or two of delay recovering from this procedure would be so critical for us to not delay the chemo and just proceed with it, which is actually not that helpful in the big picture, because the most important piece you're trying to capture at the time of diagnosis is the accurate stage of cancer. And it's very important with the new clinical trials, new discoveries, immunotherapy, when to decide on radiation, and what type of surgery to perform afterwards. I think all of that information can be captured from this one outpatient procedure. So it tells us where the tumor has traveled outside of the stomach, and preferentially the gastric cancer travels inside the abdominal wall, and you see small spots which you can't really pick up on the CT scan. And if those are positive, then the treatment regimen for you would be different. So whenever this is encouraged, there is a huge reason why we try to emphasize and incorporate that as early as we can before starting chemotherapy. So that's a key thing to remember. Secondly, when I talk about categories of gastric cancer, there are three different broad categories that are relevant. That's how I talk to my patients. It makes it very easy for them to understand why we do certain things. Instead of the 4 stages, just break it down into an early stage tumor, which is typically a small tumor. You can't really see it on a CT scan. And with advances like Dr. Kushner and some of the GI folks presented earlier, we can remove those tumors endoscopically. And if they have favorable biology, which means the final pathology tells us it was a good resection, favorable subtype of tumor, we don't even need to go out after lymph nodes or perform any big surgery. If you can comply with the surveillance protocol, which is endoscopy, which is a very important thing to consider. It's new data coming out in the last 4 or 5 years, largely extrapolated from Japan and Korea, where the incidence of gastric cancer is high. So we can eliminate the need for a surgeon. And me as a surgeon saying that tells you that I am supportive of something that can avoid a big operation if it helps the patients. So that is a new area which you're going to hear, you already heard about from Dr. Kushner, but something to talk about when the diagnosis is made. Second class, which is the most common one where you see us, is the middle stage tumors, where we don't have distant metastases, but the tumor looks like it's visible on the scan. You have maybe a positive PET scan finding, but these are the patients where staging laparoscopy tells us whether there is metastases within the abdomen or not. And those are the patients where we start with chemo, immunotherapy, and then consider surgery afterwards. The third category is the advanced or metastatic. Now, I put both of them together because it used to be metastatic stage 4, no surgery for a very long time, but that has also evolved in the field of gastric cancer. If the tumor is large, it's involving critical structures, we still need to start with the chemotherapy, confirm metastatic disease. If there is nothing visible on the PET scan, we still do a diagnostic lab if it's all advanced and confined. But one thing to consider is this important area, which is new, cytoreductive surgery, which is carefully considered in certain patients, especially at centers like high-volume centers where you have medical oncologists and team members who can select those patients for the correct operation. I'll go into a little bit of detail on each subtype that I just mentioned. So the early stage tumors where surgery can be potentially eliminated is a tumor which is confined to the inner layer of the stomach. And as you can see, if it's very small and confined, it can be endoscopically removed. And if it heals and there's no concern for positive margin, that procedure is considered sufficient. If there are positive margins or lymph nodes, we can always go after removing them surgically. And you must have seen this picture in the earlier presentation. This is how they remove the tumors, go just into the deeper layer and take it out with a negative margin. And we don't have a randomized control trial in the US, but we have a lot of data from other countries where the follow-up in these patients has been successful. The middle stage is where the tumors are advanced around the blood vessels. And I'm showing this other picture here with the green areas around the stomach. These are referring to the lymph nodes. Gastric cancer preferentially goes to the lymph nodes. So part of the surgery is removing all of these lymph nodes to know which ones were positive. The treatment is typically a combination of chemo, surgery, and the end goal is cure, which is why it's important to remember that even if you're hearing that it's spread to the lymph nodes, that doesn't mean that we're not aiming for cure. And the last one is metastatic disease, which is we start with the systemic chemotherapy, which slows the progression. It's not considered a cure, but for selected patients who have really good response, we can consider cytoreductive surgeries. I'm sure you have already seen this before, but after the initial diagnosis, just remember these are the things you have to go through before the treatment should be started. And very important to get cross-sectional imaging, whichever one is recommended by your medical oncologist, endoscopy for diagnosis, and also an ultrasound, and a staging laparoscopy, which ideally should be performed by the surgeon who will be doing your procedure so they can prepare for the surgery, whether to choose small incision surgery or traditional open approach. And I mean, you're seeing a trend that I'm emphasizing this procedure. It's important to remember it's an outpatient surgery. You go home the same day, very quick recovery, so it does not cause much delay. And I think if it helps you plan the surgery through small incisions or debulking approach, it's best to consider it. This is a warning slide for those who don't like pictures of surgery, but I'm sorry, I'm a surgeon, I have to show some of those. So close your eyes if you're scared. Okay, so this is what I mean. You can see these little dots on the inside of the abdomen which are not visible on the CT or on the PET scan. So this is what we are looking for when we are trying to perform the diagnostic laparoscopy procedure. Here's some more extensive examples. And another important thing is ascites. When there's fluid built up in your abdomen, that's also not a good sign. So we have to collect that to confirm there's no tumor in that fluid. Okay, you can open your eyes now. So this is a picture just telling you things can be good. There could be no metastatic disease on this diagnostic laparoscopy, but it could be bad news. But don't consider it that something that, oh, what if they find positive cancer on the diagnostic lab, I won't get surgery. That's not true. If you don't get surgery immediately, you still will be considered for clinical trials. And by having that access to those metastatic spots in the abdomen, we can provide a lot of good quality tissue for the medical oncologist to look for biomarkers that can help you help us identify any markers that we can use to put you on a clinical trial. So it is a good and bad news in that moment, but it helps us eventually to come up with a better plan for you. And second section I want to emphasize on is the quality of the procedure. And this is where the training and being at a Siteman Cancer Center or a high-volume center is important. You will see in all the information that they handed over to you, it's still a rare cancer in the US, which is a good thing. We want it to be a rare tumor. There are not a lot of places that specialize in gastric cancer, and primarily because there are not enough patients to be seen in one center. So there are selected areas in various regions in the country that specialize, and we are one of them because we see a lot of volume in states around here. So quality metrics for surgery is not a thing commonly people talk about or look at because a lot of patients want to get surgery closer to home, but just want to mention a few things which, if you're seen by a surgical oncologist who specializes in this disease, they're going to come up with a really good plan for your surgery. And the areas that we look for are margin negativity. We want to make sure the tumor margin is negative. And how do we know that? We will confirm that in the operating room. We have access to pathologists who can perform frozen sections right away. We also understand when we will have discrepancies on the final pathology. Lymph nodes, which is a metric which is very important. And there are certain numbers you want to be removed and visualized by the pathologist. And also postoperative complications. And most importantly, these days, minimally invasive approach is underutilized in gastric cancer, but a lot of these surgeries can be done with small incisions and robotic procedures. A little bit detail on the margin. It totally depends on where the tumor is located and how aggressive we can be. As you can see here, this black tells you how much of the stomach would be removed, but there are several different types of procedures, so it all depends on where the tumor is. The key is for the surgeon to plan what resection will get them a negative margin. Lymph node sampling is another area. 16 lymph nodes is the minimum amount that is required by NCCN for us to complete the staging. But a lot of times with these robotic procedures we have such a good visualization that we get a lot of lymph nodes in that area, which are supposed to come out because it's part of the specimen. But then our pathologists are very good about looking at them and confirming that we have a clear answer on how many lymph nodes were positive, which is going to help us decide what chemo, what immunotherapy to choose during the adjuvant phase, which is after surgery. And this is just a picture of a total gastrectomy, which is the most aggressive procedure that I showed previously in the pictures. And you can see the stomach, which used to be here, is now gone, and you have a new connection. This anastomosis, or the new connection between the esophagus and the jejunum, is a very high-risk connection. So it's good to choose a place where they do a lot of these, so they're comfortable not only performing the procedure through minimally invasive approaches, but also they're comfortable managing if anything goes wrong, which is more important thing for the recovery and making sure you can get to chemotherapy in the window that we want you to get back to chemo. And this is what I was talking about earlier, minimally invasive approach. This is typically the robot. We use the robotic assistants to perform the surgery. The surgeon is the one doing the procedure, so it's not this device that's going to do it. But we use it and it gives us like much finer and better visualization and finer dissection to get all those lymph nodes in areas that are not feasible with an open approach. Okay, another warning. Okay, so this picture actually shows you what the lymph node dissection looks like. So it's just giving you an idea where we staple the stomach. Here's the distal part of the stomach. We have to clean every blood vessel which sits in that area to make sure we get all the lymph nodes. How do we count lymph nodes? Because everything comes out as one big piece. So surgeons help the pathologist by identifying areas closer to the tumor and ask them to look for specific areas where the lymph nodes could be positive. But you can see all of this area is fat where the lymph nodes are hidden. So we have to specify where to look for those lymph nodes. And this is just one new technique I wanted to talk about. When I mentioned we don't have to always do aggressive surgery, a lot of lymph nodes. With robot and small incision surgery, you can actually see where the lymph nodes are positive for the tumor by injecting a dye into the tumor if it's an early stage. So we don't really have to do a big resection or a reconstruction. We can easily identify the positive lymph node. And just like we have done this in many other cancer types, we get to the answer very quickly with sampling just a few lymph nodes around the area of the tumor. Okay. Yeah, and this is what I was talking about, margin positivity. So when the endoscopists identify the tumor and say, for example, they've done endoscopic resection and we are going after the second time, it's good to have that communication between the GI team and us so we can plan on how aggressive we need to be with our margin resection. And you can see this is a normal stomach that has to come out just to make sure there's nothing spreading submucosally that you'll find out on the final pathology once you're in the operating room. But here you can see previous clips by the GI team where we ended up removing with a clean margin, and the patient did well. It was a final pathology, had a negative margin. And avoiding the big midline incision, small incision surgery. This is a patient of mine. You can see all these ports are very small. There's less pain. You have to make one incision to remove the stomach out, and that once it's healed, it typically hides really well. So this is like a year after surgery. Patients do really, really well. The pain control is not an issue, less discomfort, fewer complications from an infection standpoint because the incision is not big, and they recover really well. And I highly, highly encourage patients, if there's someone here with family history of a CDH1 mutation where patients need a prophylactic gastrectomy when there's no cancer, to consider something small incision because those patients are typically younger, and it's best to avoid infections and hernias from a big incision. Okay, photos are done. You can open your eyes. How to choose a surgeon. Now, this all goes back to who is the surgeon that you're comfortable with, but it's important that a few more things are considered when you're making that choice. Their expertise is important. Their experience is very important. But relationship, I usually consider that as one of the areas that only the patient can tell how you relate to the surgeon, whether they have the experience, expertise, and all of that. And don't forget, logistics is hard for the main operation that needs to be done at a high-volume center, but that also is important to have a surgeon locally that you're comfortable with who can help you with the post-op small complications, but in addition to a surgeon who's going to be doing your surgery, which is going to be away from home. So these days, the training processes have evolved for surgeons and for medical oncologists. Everyone specializes in certain areas. So surgical oncology is a training that trains patients really well for gastric cancer surgery. It's important to know, or at least these days everyone can Google your surgeon. Google your surgeon, ask ChatGPT whether they have a presence nationally, and do they know how these guidelines are evolving. And why is that important? It's because if things are evolving in Japan and our patient fits into the same category, we shouldn't be hiding or not being aware of those new discoveries, and we should apply those to our patients. Experience, you can easily ask them or search on the website for the cancer center. It typically depends on the center because it's a rare disease, so it's not like you do one every day. The volume is just not that much, but just the comfort level and how much resections in the institutions have performed, I think that's the kind of thing you should ask questions related to that when you're seeing your surgeon for the first time. And also ask them a little bit more about the margins, or what are the things they will be looking for, what to expect on pathology. That just tells you how much they have thought about it, or how much are they aware of the guidelines. Relationship is going to be the key, so how you relate to the surgeon. And most of us are really good at doing a really good job explaining, but we're also fortunate to have our team members like nurse practitioners, physician assistants, who you can reach anytime, even if you can't get a hold of a surgeon or a medical oncologist, and they would address a lot of your concerns. And finding a tertiary care center or a big center where there is a cancer center ideally affiliated with the hospital gives you the best access to clinical trials and most high-end procedures that are out there now. But I mean, it's important to figure out a way to coordinate your care between your local team and a cancer center where you're going to be getting your surgery. Now, remember, all surgeons have complications, so there's data out there where you can see if surgeons have certain complications or from procedures. So the most important thing is, yes, there will be a complication, but do they have the capabilities to manage it? So if you're in a small hospital, the GI team might not be comfortable going in to stent across a leak or something, but there are procedures that we can do at a tertiary care center where we can manage those complications without the need for another big operation, and a lot of those things can be managed endoscopically. Okay, I just have to end with this. It's an English proverb, which I'm sure you guys will understand why I'm saying. For a surgeon, look for 3 characteristics. Okay, I'll be happy to take any questions. Thank you for your attention.
Since we're running a little bit behind, is it okay we hold questions at the end? We'll have our discussion. You'll be around, Dr. Panni, right? Okay. And then I guess our last speaker for this session is one of my partners in medical oncology, Dr. Patrick Grierson. He's assistant professor, Division of Oncology. He's going to talk about clinical trials here.
Is it the button or the mouse? Hey, good afternoon. I'll be relatively brief. We're a little bit behind, but so a lot of these slides are a little bit more high level. They're not real nitty gritty. I wanted to give kind of a good experience to all the patients and family, in the audience. So generally speaking, a quick overview of clinical trials, partially what trials we have, and a little bit more of what are trials and how do they come about. So let me see, is it down? How do I advance? Is it down or over?
I think you can just...
See, is it advancing? Click. There we go. This is a real big kind of 101 slide, just to get everyone on the same page. So kind of cancer drugs one-on-one, right? Oftentimes when we talk about treatment for cancers, we use the term chemo very loosely, but there's some more technical verbiage to kind of go over. So chemotherapy specifically are cancer drugs. They kill cancer cells. They're generally toxic drugs. Many have been around since the 60s or later. There's many of them. I won't get into all of them, but generally speaking, they're drugs that work broadly and kill cancer cells. They're tailored to different kinds of cancers, but as a whole, they're broad drugs that kill cancer cells. Then we get into what's called immunotherapy. These are drugs that work by kind of turning on your own immune system, so your immune system is no longer blind to the cancer, and your immune system can seek out and kill the cancer. So it helps your body fight your own cancer with you and for you. In contrast to chemotherapy, when we talk about gastric and esophageal cancers, The immunotherapy drugs we have at present, there's 10 or so are kind of FDA approved. The first approval is only in 2019. So we're only talking about 6 years since the first approval of an immunotherapy drug for gastric and esophageal cancers. That really speaks to how young the field is and why right now we're on a very kind of exponential uptick in the science and the clinical implementation of the science. So this is a very new emerging field. Targeted therapy, we've already touched on a little bit. These are drugs that target a protein or a marker on the cancer and kind of turn off the cancer or thereabouts in some particular way. A marker is HER2, another is the CLDN 18.2 or Claudin, another is VEGF. They all have their kind of cognate drug that hits that target and blocks the cancer from growing in some capacity. The final thing, which is much more on the cusp, is cellular therapy, also called CAR T cells. It stands for chimeric antigen receptor T cells. I'll get on, there's a slide later on this, but these are generally cells that are more or less usually the patient's own immune cells that have been taken out of their body, genetically modified in the lab, kind of revved up, so to speak, and put back in you to kill your cancer on hyperdrive. These also can be done kind of off the shelf with a generic drug, but oftentimes it's your own cancer cells that we're tweaking. So how are new drugs developed? One quick slide here. Research and clinical trials is how this happens. So research starts in the lab with preclinical research. We call it bench research. Cancer cells in a petri dish or animal models, usually mice in this day and age. This is really where new ideas are come up, new ideas are tested, and real new breakthroughs are made, and scientific advances are really made, at least conceptually. Then once we have something through the lab or coming to clinic, then we do a clinical trial. Clinical trials are in 3 phases. There's phase 1 clinical trial. This really means first in human, right? First in man, first in human. The goal is to establish how safe is the drug, what side effects does it cause, is there any sign of that it maybe works, and what do we think is probably the good dose that's going to be feasible here. Once a drug graduates phase 1, then it moves to what's called phase 2. So this drug has been tested for safety. We know what the side effects look like. We generally know that it has some effectiveness. And now we're trying to get more of an objective assessment of really how effective do we think this drug is. If a drug clears phase 2, we get into phase 3. Phase 3 is where the drug is pretty much put head-to-head against the current state-of-the-art. So if we have the current state-of-the-art, treatment, whatever it needs, whatever it is, when we have a new drug that gets to phase 3, we're oftentimes comparing it side by side and saying really exactly how good is this new drug? Is it kind of better than the best? Is it good enough to become a new FDA-labeled drug? From the lab through phase 1 through 3 is usually about a good 10 years or so. This takes a lot of time and a tremendous amount of resources and money. So, and we're stuck again. Here we go. So this is another kind of schematic. This is not to be kind of scrutinized, but generally speaking, in the lab, someone comes up with a concept in their mind. They do some experiments that seems to kind of hold weight. They test it in animals, usually mice. When they combine drugs 1 and 2, they find that drug 1 plus drug 2 shrinks tumors a lot more than either one and a lot more than no drug. That's a real kind of simple assessment of how do we think these things are working in the lab. And then we move that into a clinical trial. This is a generic clinical trial schema where we're kind of showing in kind of a schematic format how we're going to use the drug with the standard chemo cocktail. We'll prescribe the dose levels that we're going to do with the drug. And then we have kind of a program of how we're going to enroll patients and get biopsies. What's really important to keep in mind is that all of this is more or less over years a circle, right? It comes and goes and comes and goes, meaning that when patients are on a clinical trial, we are often getting biopsies when they start and then a biopsy a couple months later. The reason is, based on this science up here, we're pretty sure we think we know how the drug is going to work in the person, but it doesn't always materialize. So during the trial and at the end of the trial, we get a tumor biopsy that frequently goes back to the lab, and we can assess, did it really do what we thought it was going to do? Did the drug do what we thought it was going to achieve? And if not, perhaps how and why? And once we get that how and why, that leads to version 2.0. And now we have a new drug, and we cycle it back through. So this is kind of the cyclical nature of clinical trials in general. Let me see, here we go. So the last couple of slides are just some select trials at Siteman. Somewhat high-level slides here, but generally giving you kind of an overview. So the first thing to kind of state about clinical trials is trials are always positioned at a particular point, right? So if we look at someone's journey, so to speak, they're diagnosed here. Hopefully we're going to surgery. If they don't go to surgery or after surgery, the cancer may come back or spread. These are all different frameworks. These are all different scenarios. So we have clinical trials, each of these green boxes, at different places depending on where we are and what we need to achieve. So for a lot of these cancers, we start off with radiation or chemotherapy before surgery. So we have a trial here by one of the radiation oncologists where we're doing a modified radiation plan with chemo before surgery. Also, like the radiation oncologist mentioned a few minutes ago, is there's two different natures of radiation. There's proton and photon radiation. We have a clinical trial where we're testing proton versus photon radiation to determine which one is better, what are the side effects, and what are the outcomes. If patients clear surgery, hopefully we never see the cancer again. But if we do see it again, now we're talking about metastatic or stage 4 cancer. If someone is receiving their first chemo program, we call that first-line treatment. It's their first program they're seeing. We have several first-line clinical trials, one of which I'll go into next is homegrown from WashU entirely in terms of its scientific discovery. Another one comes from a pharmaceutical collaborator, Henlius, that's using another chemotherapy combination with that HER2 targeting. If a patient receives one of these and then their cancer still grows and spreads, now we have other second-line clinical trial options. These are all positioned in a specific point for good scientific and kind of medical rationale as to why you should get A before B, for example. If we still have more cancer growth, then we can get into third-line, second-line plus trials. Some of these I'll touch base in a little bit here. A lot of these trials are chemotherapy-based, but the second-line plus trials that we have specifically that I'll delve into are some of what's called CAR T-cell studies. They're more advanced, they're more scientific, and I'll touch base on that. So one of the trials I'll kind of jump into specifically, and you can kind of see how, kind of the thought is that Dr. Jin mentioned, more than once about our chemotherapy programs, the chemotherapy called FLOT, and we do what's called perioperative chemotherapy. Peri means around. So the standard approach in this current era is that patients may get the FLOT chemotherapy for 2 months, and then surgery, and then 2 more months of chemo. Other patients, for various reasons, may get more of a chemo radiation alone, and then surgery, and then you're done. This is generally a very standard paradigm. One of the challenges that we see in the field is after undergoing surgery, patients are not doing quite as well as they were when you met them. So chemotherapy is challenging. As many of you know, the surgery is challenging. And although we intend to give people 2 more months of chemo on the backside, nowhere near 100% of people are actually able to get that. Maybe 30 to 60% are actually getting it. So one clinical trial concept that's kind of come up between one of our radiation oncologists is to do a total upfront program. We call it total neoadjuvant, or TNT. So a clinical trial that we're going to be launching in a couple months here is going to be starting off with 5 days of high-intensity focused radiation on the tumor in the stomach, and then doing all of the FLOT chemotherapy ahead of time, and then doing surgery, and now you're done. So the concept of this is to more or less rearrange the parts of what's been done for many, many years, using the same tools but putting them in the front, in the thought that if we do it all at the beginning, we'll have more people that complete all of the planned chemotherapy without having complications and having to cancel it, and we may actually have better cancer control by hitting it with radiation and the super high potency chemo that we use. This is kind of a concept of what I would call a high-level clinical trial. We're not using new drugs. We're just simply kind of rearranging the pieces with a good kind of rationale to improve success rates. This trial is much more the opposite, which is trying to identify a new drug that might increase success rates in these cancers. So this is not so much rearranging the tools. This is more, can we find a new drug that can lead to somewhat of a soft breakthrough, so to speak. So this is a clinical trial that was pioneered. The science of it is entirely by one of our scientists here, Dr. Kian Lim. And what this is a clinical trial where we're using standard chemotherapy called FOLFOX, an immunotherapy called nivolumab or pembrolizumab, and an oral drug called CA-4948. This is for people that have stage 4 or metastatic esophageal or gastric cancers. And this is the laboratory research that was done here, where this is a survival plot of mice in the lab. So if you look over time, from day 0 to 70, all the mice start off living, and now they're no longer living. This is what happens when you leave them alone with their cancer or give them some of the standard treatment options. When you combine that standard treatment option with a newly discovered drug, now the survival curve is more this red line. So this is some pretty exciting research we've done here in some of these gastrointestinal cancers as such. With that, we've launched a clinical trial that's really actually only going on here at Siteman in esophageal and gastric cancers that are stage 4 metastatic, where we're doing more or less this. So we're giving patients the standard chemotherapy called FOLFOX, combining it with the immunotherapy called nivolumab to kind of rev up the immune system, and we're adding on an oral drug called CA-4948. This is a drug that's going to help the immune system see the cancer and fight the cancer, and it also helps weaken the cancer so the chemotherapy can kill it better. So it's hitting it in a two-pronged manner. And what we're doing is we're giving patients escalating doses of this drug and treating them with it, getting biopsies and following their scans. This specific clinical trial is still ongoing. It's not yet published. We've been doing it for about 2.5 years. And so far, the comparator statement is that for most patients that get this treatment can usually hold patients' cancer at bay for somewhere on the order of 6 to 9 months or so before it grows. We've had patients where the cancer has not grown for 2 years on this trial, and it had actually gone into remission for a time, which is quite remarkable. We need to treat more patients in that capacity, but so far this is looking exciting, at least to our eyes. But again, this is considered a phase 1 trial because it's considered first in human, okay? If this continues to go well, it may become phase 2, phase 3 in the future. The next slide is on CAR T cells. I won't really go into the nitty-gritties, but just to kind of get a flavor of what these are. They're getting a lot of press and a lot of news these days for good reason. So CAR T cells are essentially genetically modified cells that usually are your own. So what happens is we have a patient and we do a large blood draw to remove some of their immune cells. We send it to a lab and they're genetically modified to seek out a cancer with high kind of aggressiveness, so to speak. In the lab, these cancers are multiplied to the millions. And then we have them shipped back and infused into the patient, and now the patient is receiving their own kind of native cells that have been kind of amplified and activated to seek out their cancer. And the goal is that these cells in the patient will seek out and kill their own cancer. So this is a concept that's been going on for about 15 years or so in leukemias and lymphomas. It's very, very new in solid tumors. None of these are FDA approved for gastric and esophageal, but these are exciting things. The way that these are done is the cells are essentially programmed to seek out a specific target on the cancer. So there has to be kind of a target or a bullseye on the cancer that the cells are geared to attack. One of them is an oncogene called KRAS. So KRAS is a notorious kind of gas pedal that fuels cancer growth. One clinical trial called NT112 is using these cells and modifying them to attack KRAS. Another one is modifying them to attack what's called HER2. Another one is modifying them to look at other various surface markers on the cancer called mesothelin or EGFR. These are not pioneered or developed at Siteman. These are large pharmaceutical companies that were one participating site. So this is kind of an exciting thing that's kind of on the cusp. We do have some of these that are available, but they're not FDA approved, but you'll hear probably much more about them in the future. So one quick summary slide, I think we're short on time, is generally speaking kind of some high points, take-home messages for clinical trials, is they are a developmental process in which we develop new anti-cancer drugs. It's a slow, methodical, scientifically driven process. We view it as a process to provide patients early access to late-breaking new drugs, right? Because a lot of drugs might take 5 to 6 years to go from phase 1 to phase 3. Many patients have already been on it for 5 years once it gets FDA approved. So they were benefited by having that drug 5 years ago. They're generally orchestrated at large universities and cancer centers. You're not going to find these much in small, single operation community cancer centers. And again, they're positioned strategically at different steps along the cancer journey. Are you newly diagnosed pre-surgery? Are you post-surgery? Or are you dealing with a stage 4 metastatic cancer? And is it your first, second, or third line? Clinical trials are also very strict in terms of patients that we can enroll on them. We need patients to be of a certain good kind of physical performance status, as we call it. They have to have the right cancer type. They may need the right molecular marker. They have to have good kidney function, liver function, heart function, et cetera. So there's a very stringent process of scrutinizing someone before we can put them on a trial. So I say that in the sense that oftentimes we're disappointed that we can't offer someone a trial, but it's all in the name of safety and appropriateness that they're likely to benefit in a safe manner. That's the whole overarching theme here. And lastly, your oncologist always has this in their back of their mind. Every step along the journey, we're always weighing what are the standard FDA-approved options, what are the clinical trials, is it likely to be helpful, risky, and how's that going to go for this patient? And that's kind of how we decide if we should or shouldn't offer one at a particular time. So that's really it. It was kind of high level, not real nitty gritty. Hopefully it was helpful. I think we can take questions.
I think we're going to go to our discussion. I know we're about like 2-3 minutes from lunchtime. If we can do like a maybe 5-10 minute discussion, that'd be great. Can Dr. Panni, you want to come down here, and maybe we can put Dr. Vlacich back up. But I think one of the discussion points, and we've kind of talked about, is this changing landscape of how we treat esophageal cancers. Perioperative chemotherapy is now, possibly the standard. Shifting away from that chemoradiation. So can we go on to the next slide? So here are some kind of discussion points, and I don't know if Dr. Vlacich is on, but maybe he can talk about dosage of radiation. This cross trial, that was the comparator, only used about 41.4 gray. Can you talk about, what we actually do in the clinic, and how does that kind of change that data? Might not be on. So I guess if he's not on, I'm just going to keep this moving then. I talked about the path CR rate, so that is just one measure. And Dr. Clifford Robinson and Dr. Pam Sampson really made a point that that's not the end-all, be-all, that in addition to cutting out the tumor and...
Dr. Jin.
Oh, hi.
Yeah, sorry. I was waiting to get unmuted since they have us.
Yeah, please, Dr. Vlacich. We can't see you, but we can hear you. So you want to talk real quick about kind of the dosages?
Yeah, sure. So, in the preoperative setting, sorry, I'm going to mute my side. The cross trial, they had, and I kind of alluded a little bit to this in my talk previously, but their dose was 41.4 gray, which is a lower dose than we would normally do in the definitive setting, with the thinking that these patients are going on to surgery. So it's less about complete tumor ablation than it is about cleaning up the surgical field and allowing for a margin-free resection. But other studies that looked at radiation treatment in the preoperative setting have had variable radiation doses, with different dose and fractionations that But we typically will just sort of land on our definitive dose, whether in the preoperative or in the definitive setting at 50 gray, so slightly higher than the cross regimen, because that's where we can get better local and regional control in case they don't go on to surgery. As I sort of mentioned a bit in my talk too, we looked at whether we can escalate the dose of radiation therapy primarily in the non-surgical setting, and we haven't seen any additional benefit but more toxicities in that space. And so we're still kind of deciding as a field whether that's something that is really meaningful or not in this disease site. But those are kind of where where radiation sort of kind of fits in as far as the dose and fractionation.
Perfect. So I guess my next kind of discussion point, and this is for Dr. Panni and Dr. Brandt, is, we've shared a couple of patients that have already gone through kind of this ESOPEC FLOT regimen. Can you talk a little bit about your experiences, surgery after, chemo rads as to kind of FLOT chemotherapy by itself?
So I think we talked about this slightly earlier, and nationwide for esophagectomy, there's been a push to do more minimally invasive surgery. As you saw, the outcomes are just, the long-term outcomes are the same, but the perioperative pulmonary complications are certainly less, and there's less morbidity for the patient. A lot of surgeons nationwide have tried to work within their institutions even before the ESOPEC trial came out to avoid preoperative radiation in those patients, in part because making the conduit is slightly different, open versus robotic or minimally invasive, and in order to decrease a leak risk from the radiation field. And then also the ease of the operation is much better, or easier. Not always, but sometimes without radiation. So there is some push in multiple centers now that we're moving towards minimally invasive resection to try to avoid radiation. And that kind of correlated with this ESOPEC trial coming out. So for us, I will say I think it does make the operation easier without radiation, and it makes our ability to do a minimally invasive resection more easy as well. So that's the one surgical standpoint outside of PCR discussion.
I completely agree with what Dr. Brandt has just said. For the gastric cancer specifically, radiation doesn't, in the pre-op setting, is not even something we talk about for the right reasons, because it just doesn't cover the field unless we know that we will not be able to do the surgery. But for the G-junction tumors, I think one of the complications nobody wants for any of their patients is a leak. And that is what Dr. Brandt is referring to, especially when she says it's easier. It's easier not just for us, it's easier on you to not have that complication and recover and go back to your treatment. I've noticed that chemotherapy is typically pretty well tolerated, and I actually, nationally, the trend is now moving towards the TNT approach. Previously, we used to do half chemo before, half after, but after a procedure like total gastrectomy, there's quite a bit of adjustment to your new lifestyle on how to eat, and portion size, water, and all of those things. Everything is completely different than what you used to do before. So for my own patients, I have noticed that it's well tolerated when you have your stomach and the luxury to eat whatever you want when you're getting through all the chemo. So unless you have side effects where we have to really stop the chemo, preferentially finish everything beforehand and then come for your surgery. So after the surgical resection, all you have to worry about is getting used to the new lifestyle of eating.
So this kind of highlights what Dr. Panni has talked about, and Dr. Grierson really highlighted this. So this is from that ESOPEC trial, but basically 35, almost 36% of patients on the back end weren't able to start that post-operative chemotherapy because of various complications, or just the patients didn't want to. Dr. Grierson, do you have anything to add to your experiences with perioperative FLOT or durvalumab?
No, nothing too resistant.
Yep.
Nothing too notable, no. I think that, moving towards the kind of all front or total neoadjuvant approach is probably the best, right? You have a better rate of getting all the treatment done beforehand, less need to do it afterwards when you're dealing with other challenges. And adding the immunotherapy, I think, is clearly the way to go. The outcomes are unanimously better that way.
I think one final point, we're running really, really short on time, is kind of patterns of failure. So, how do these two regimens, when they do fail, how do they fail? So we can look at the FLOT regimen here. And what really, this is heavy chemotherapy. So most of the patients who fail are going to have kind of, when compared to chemoradiation, they're going to fail locally. So they're going to fail kind of where that primary tumor is. It's going to grow back. But where kind of, so that's where kind of the strength of chemoradiation, it does probably a better control of local control. But where, that cross or chemoradiation really fails is kind of, when it does fail, most of the failures are distal. So that chemotherapy given with that radiation is less strong. So those patients kind of have metastatic disease on failure. So I think I'm going to just kind of close here with a final slide, as Dr. Grierson kind of mentioned, addition of immunotherapy. We talked about kind of the safety side effects, and I think the important thing is, we can't treat this as kind of absolutes. It's great. We have to individualize these treatments for the patient, and we have to have discussions, multidisciplinary with the surgeons, with the radiation oncologists, and with medical oncologists. So thank you. Lunch will be served. Oh, please join us. We're going to have some posters up from our basic science labs, mine, Dr. Sands, and Dr. Brown's. Please come talk with us. And we'll be back here at 1.
Yeah.